I'm going to talk about etiology and precipitating factors in India. Are we different from the West? If we look at the data which is available in India, it is mostly in the last decade and mostly in acute decompensated heart failure. There are very few registries in chronic heart failure, and unfortunately, follow-up data is lacking in many of these registries. We have many states and languages, varied culture, different socioeconomic status, so each registry does not represent comprehensively what is happening in the country. If we look at the prevalence of heart failure worldwide, and Dr. Rath mentioned that we are catching up with the West, although worldwide it is a huge problem. And doctors, in a way, are contributing to this epidemic of heart failure because we're treating more patients of acute MI, hypertension, diabetes, which ultimately goes on to heart failure. If you look at heart failure in India, there have been older registries, which are about 25 to 30 years back. One of them was an Indus study, and it studied about 10,000 patients and found a prevalence of 1.2 per 1,000. And rheumatic heart disease contributed significantly at that time, which was about 52%. And younger people were affected for heart failure because it was the rheumatic heart disease population. And it was projected that the heart failure population will increase. But contemporary registries have looked at it. We have heart failure CHS registry, and it has shown that if compared to the rest of the world, we have increased mortality at 1 year as compared to the European population and even some of the Asian countries. Now, this inter-CHS study, if we look at India versus the West, patients were much younger. They had lower education status. They were more symptomatic, and their low rate of health insurance and out-of-pocket payment was much more. And more often they were treated with digoxin, and they are more often from the rural area. There are many good registries which have come from Trivandrum, and Trivandrum heart failure was about 1,200 patients. Medanta, which is a single-center retrospective study, enrolled about 6,000, studied about 6,000 patients. Then we had multiple national heart failure registries at different times, enrolling more than 5,000 patients between 2018 and 2020, and again 5,000 patients from 19 to 22. And then we have CSI Kerala heart failure in-hospital registry, about 7,500 patients, and an ICMR national heart failure registry of about 10,000 patients. If we look at the Trivandrum heart failure registry, it's a prospective hospital-based registry, both urban and rural area. Patients were divided into groups of heart failure with reduced ejection fraction and heart failure with preserved ejection failure, and it has a very high mortality at 1 year. 31% patients were women, and we would talk about it a little bit. And greatest mortality was in the first 3 months, which was about 18%, and mortality was more in the heart failure with reduced ejection fraction. Then we had the ICCI National Heart Failure Register, which was published about recently in the Indian Heart Journey. It showed the etiology factors. Ischemic heart disease contributed about 70% of these patients. Dilated cardiomyopathy was seen in 13%. And as compared to earlier study of Indus study, rheumatic heart disease was very low, only about 5% patient. Congenital heart disease in the adult population only contributing 1% of patients causing heart failure. In hospital, CSI Kerala acute heart failure registry showed almost similar data. It studied acute heart failure in 50 hospitals across state of Kerala. And Kerala has the highest literacy, highest health awareness. So it is not reflective of the national scenario, but it is very, very nicely conducted study. And it showed that mortality in hospital 7%, 90-day mortality was 11%, and rehospitalization 11.4%. Then we have a national heart failure registry, and it showed that the mean age was about 60 years. There were about 70% male, and ischemic heart disease again contributed about 72% of patients. Rheumatic heart disease only 6%. Hypertension was seen in 50% patients. Diabetes, which is a rampaging epidemic in India, contributed about 42% of patients. CKD was seen in about 8.5% and atrial fibrillation and 9.5%. So if we look at the contemporary data, ICS National Heart Failure Registry, 1 and 2, CSI Kerala Heart Failure Registry, in-hospital mortality about 6 to 7%, higher prevalence of hypertension and diabetes, ischemic heart disease is the commonest etiological factor. Unfortunately, follow-up remains an issue. So what we have learned from this thing that over the periods, prevalence is more and younger age is seen, patients are seen at a younger age. Ischemic heart disease is the commonest etiology, contributing about 75%. Rheumatic heart disease over the year has decreased to less than 5%. Diabetes, hypertension are seen in about 50% of patients. CKD in 15%, atrial fibrillation about 8 to 9%, in hospital mortality of 6 to 8%. But a significant mortality at 1 year, and GDMT usage is low, still very low, 25%, and RNA are used in less than 2% of patients. So heart failure data in India, ischemic heart disease in various studies has contributed from 65 to 75% of patients, diabetes from 12 to 18%, and as far comorbidities are concerned, hypertension about 50%, diabetes in about 42 to 61%, atrial fibrillation from 5 to 9%, and CKD from 8 to 14%. So prevalence is more in younger patients. Ischemic heart etiology is common. Diabetes or hypertension are seen in 50% of patients. So this is a very busy slide, so I'm not going to read it. But various studies have shown that we are dealing with a younger population in about 60 years of age. Ischemic heart disease is seen in about 70% of patients, hypertension about 50% of patients across different studies. So if you compare mean age of different Indian registries, mean age is about 60 years, which is younger population, and we'll come to it in a short while. And ischemic heart disease in various registries contribute from 65 to about 70% of patients. Let's look at the global data. And we have ADHERE registry from USA. We have optimized heart failure registry. We have SPEED heart failure registry from Europe. Then we have inter-CHF registry. We have Asian heart failure. We have Gulf Care registry. And we'll see an overview of this. ADHERE study enrolled more than 100,000 patients in about 275 patient hospitals, and the mean age was 75 years, and about 52% were male. Ischemic heart disease contributed about 54%, hypertension was seen in 30%, and valvular or other disease was seen in about 16%. If you look at this 3D heart failure, again, a very robust data, 120,000 people enrolled, mean age 74, etiology, ischemic heart disease seen in 55%, hypertension in 20%, valvular heart disease in 7%, and 18% had idiopathic, what we call as a dilated cardiomyopathy. So important demographic findings in the SPEED heart study was mean age 75 years, male 60 to 65 years, atrial fibrillation seen in significant proportion, about 48%, hypertension in 52%, ischemic heart disease 54%, diabetes in 24%, and chronic kidney disease in 44%. So these are the major comorbidities which are seen. And we look at the European heart failure study, long-term follow-up, and it enrolled patients from Europe and Mediterranean, and about 20 countries participated, and ischemic heart disease was seen in 53%, hypertension in 22%, valvular heart disease in 8%, and idiopathic in 17%. We had a subgroup analysis of this study with the Egyptian study, which showed that patients were younger, 58 years, more male, 72% or more ischemic heart disease, 58%, and more diabetes, 48%. So etiology across different heart studies, if we see the European, US, and the Indian heart study, Indian registries, the mean age in Western country is about 74 to 75 years, and in Gulf is about 60 years, European again 65 years, predominantly contributed by a large data pool from Egyptian population, And in India, it is about 58 to 60% of patients. And ischemic etiology in Indian registry is about 70%, whereas in the Western registry is about 50 to 55%. Hypertension in India is down to 12%, whereas in ADHERE and sweet heart failure, it is 20 to 30%. Valvular heart disease is almost similar, but in Indian subset, it is a different type of valvular heart disease we deal with, whereas in the West, more structural degenerative disease is more common. So if we look at this comparison of different registries, and we look at on the left side, we have National Heart Failure Registry, that is the prototype, and the Kerala Heart Registry. Ischemic heart disease contributing to 70%, and hypertension is lower, whereas Western studies are showing ischemic heart disease about 50 to 55%, and hypertension in about 30% of patients. More ischemic in Indian population, less hypertension. Valvular heart disease is almost similar. So let's come to the precipitating factors that cause acute decompensated heart failure. Unfortunately, many registries don't look at this data specifically, so we have limited data on that. So what are the factors which have been looked in different registries? We have non-adherence to diet or medication, infections in the form of pneumonia or sepsis, uncontrolled hypertension, arrhythmias, ischemic heart disease, renal dysfunction, or excessive intake of alcohol or drugs. And ADHERE data from US and the SWEET data have not specifically looked, at least has not been published, and I could not come across the data from these registries. This is the data, again, a very busy slide. It shows that ischemic heart disease, if a precipitating factor we are talking about 25% are ischemic heart disease and 25% or so are infections. This is a comparison between Indian studies and different other studies. I've included ADHERE and SWEET to say the data is not included from here. In South Indian study, one of the study from Coimbatore, ischemic heart disease was seen in 24%, infection in 23%, arrhythmias in 12%, uncontrolled hypertension as a precipitating factor in 10%, and non-compliance in 14%, and renal dysfunction progression in 17%. Compare it with the European population in the long-term follow-up. Ischemic heart disease was seen in 27%, and arrhythmia infection in 18%. Lesser infection, a little more ischemic heart disease. So this is the precipitating factors comparison between Indian study from Coimbatore and various European study. So the key messages are, Indian heart patients are younger as compared to Western population registries. Male predominance is seen in India, which is a cause of concern. We need to enroll more female patients. Ischemic heart disease is the commonest etiology. National Heart Failure Registry provides first national snapshot, and Trivandrum Heart Failure Registry and CSI Kerala give a regional long-term insight. We need to capture precipitating factors more robustly. And as far as the etiology is concerned, ischemic heart disease is a leading cause in many cohorts in Western countries. Hypertension and valvular disease contribute about 15 to 25%. There's a high prevalence of CKD in Western population, as is the Asian population in this group. So if we look at worldwide scenario, in North America and Europe, coronary artery disease predominates to the tune of 70%, and in Latin America, we have some infectious diseases. Thank you. Thank you very much.